You know you have one heart, but you have two kidneys, one liver, two lungs, and for this podcast, we're going to talk about our one appendix and our one gallbladder. And by the way, if you've listened to previous podcasts, we also have 206 bones as an adult. But some of you know that you can live with only one kidney. You can live with one lung. Many of you already know somebody or are familiar with someone who has no appendix or no gallbladder, and we want to learn more about that. I'm Dr. Daniel Haight, host of Lakeland Regional Health's Inside Scope. And with me today are two physicians very familiar with the appendix and the gallbladder and all spots in between. They handle everything from routine to emergencies in these areas. Dr. Zachary Boucher is a general surgeon and assistant professor of surgery at Lakeland Regional Health. And Dr. Michael Taylor specializes in general surgery in addition to trauma and critical care surgery. Welcome, and I think I want to start first with the appendix. You know, that's something that a lot of folks are common with. Where exactly is the appendix located, and what does it do?
Yeah, so the appendix is part of your large intestine, kind of located on the bottom right side of your abdomen.
Bottom right. That's really helpful because a lot of folks get belly pain and they start to think.
Absolutely. Historically, we didn't have a great idea of what the appendix was or what it was for. We thought it used to be an old organ that maybe had some utility way back,
30,000
thousands of years ago. Absolutely.
Yeah. Mm-hmm.
Now we're learning that maybe the appendix probably serves as a reservoir for some of the bacteria that normally live in our GI tract.
So we have friendly bacteria that live in our guts. And so our friendly bacteria, they help digest our food. But every now and then, if you've got a really bad case of diarrhea, I guess you'd call those the unfriendly ones, take over. But your appendix might be, a safe harbor?
Absolutely.
Okay, yeah.
We actually have more bacteria in our GI tract than we have other cells in the rest of our body. They're that numerous.
So what could, Dr. Boucher, what could possibly go wrong in the appendix with those bacteria in there?
Yeah, so I was going to throw this back to Dr. Taylor, actually, because, I think that if I were to need my appendix out afterwards, I wouldn't necessarily be worried about my microbiome being messed up. You know what I mean?
Because appendix, you almost have to get it out if it's misbehaving, or?
Right. In most situations, it's super obvious. And most of the time, the appendix gets occluded with like a hard stool ball, actually, which means it can't drain very well, and the venous blood supply gets sort of cut off, and then it can perforate or explode, and we want to get to it before that happens.
And, I love that in medical school, we always talked about the beginnings of appendicitis start as this vague in the center of your belly, and then the pain actually moves down to where you said it was in the bottom right. That's always a concerning story if I hear a family member calling me from a far away and they're like, I have this belly pain, I'm a little nauseated, and what are the red flag symptoms if you've got pain in the center, it's moving down to the bottom right? What are some of the questions you're going to ask? If folks are just starting to get that, what are some red flags?
Yeah, so, classically you'll hear, inflammation of the appendix described as this pain that starts by your belly button, and then it kind of comes out of nowhere, typically not brought on by doing anything. And then over time, it may migrate or move to somewhere else in the belly.
Mm-hmm.
Kind of things that we look for or we ask people about when they come in with this concern is, when did this start? Has this been going on for several days or several weeks? Or did this kind of start out of nowhere, happened this morning or woke you up overnight? How is the pain moving? Is it moving? Are you having any changes with how your GI tract is functioning? Have you been nauseous, tolerating food, having changes in your bowel habits, to kind of pull the whole picture together?
So you get a good idea because every patient's unique. Would you say the appendix is, compared to my little finger, is it smaller than my little finger, or is it about that size?
I'd say it's a pretty good analogy. It's probably a little smaller, realistically, but yeah, I think it's a pretty good analogy.
And I know with the appendix, it can be slightly in one place for one person and slightly different. And if it gets angry and inflamed, you're saying it's going to feel different for the patient. They may have certain leg movements hurt them or trouble walking. Yeah, so is it, at what point does this become more urgent and you're gathering this information? What would be sort of the emergency aspects?
We we take kind of the whole picture together. As you talked about, as the appendix is inflamed, our body doesn't really know how to say, hey, my appendix hurts. But it knows how to say, hey, that this area is uncomfortable and upset. And that's what we call referred pain. So you don't know how to process my appendix hurts, but we know, oh, my
something's
belly
going
hurts
on down
or
there.
my hip hurts. And kind of depending on where the appendix is sitting, is it overlying muscles that kind of go down your back to your leg, may present with a little bit different symptoms.
It feels different.
And so kind of pulling that whole picture together. And then we're also able to add on, what kind of studies and tests may they have done in the emergency department.
Just to confirm it. And then once the surgery goes, do you have options, Dr. Boucher, as far as the doing it with what used to be the old open scar, or with laparoscopes or robotics? With the appendix, how does that sort of fit in on how you're going to treat it surgically?
Yeah, sure. Now, this is an example when I'm very thankful that I'm a physician practicing in the 21st century in adults, because it makes the diagnosis for us extremely easy compared to what it used to be. Before we had CT scans, we had to just be super good at physical exams and kind of like figure out clues of the patient's presentation.
Sometimes it was an appendicitis.
The CT scan tells us the answer 99% of the time here. And so with kids, you don't want a CT scan every kid. So when we practice on adults, so it makes our job a little bit easier. But yeah, we used to do the surgery with a bigger cut, usually right over the appendix. So it makes sense. You make the incision where the surgery is. But now, like, appendectomy, or taking the appendix out, is sort of like one of the poster trials for minimally invasive surgery, where it really improved outcomes, got people out of the hospital faster, made a surgery that was kind of before just shoving your finger in, fishing the appendix out and cutting it off. Now it's extremely elegant. We can get it in hard spots and
with just tiny incisions.
Exactly. It's 3 small cuts. The question of robot or not is actually a little controversial in the surgical realm now. Some people think it's a little overkill robot. Some people think it's a great utilization of the tool. But either way, small cuts are better.
But I do want to follow up with a previous podcast that we did. Is we talked about hernias, and hernias after surgery sometimes occur, but it depends on the surgery. What about appendectomies and hernias? Would you say those happen?
So when we transition from bigger cuts to small cuts, the number of hernias just dramatically dropped off.
Oh, that's
right?
good. That's good news.
Yeah.
So and that's the kind of, I think we were talking before about what were the kinds of questions you want patients to ask. And when you're going to be doing an appendectomy, what do you want the patient and the family to be asking or to be thinking of? What are some common questions?
Yeah, so common questions that we receive are, how am I going to feel afterwards? When can I leave the hospital?
And when can I go back to
When
work
can I go back to
do
work?
what I like to do?
I'll be honest, and I tell my patients this, I've never had my appendix out. But in the multiple patients that myself and my colleagues have done, speaking with our patients afterwards, they say that deep down nasty feeling goes away almost as soon as they're waking up from anesthesia. And they start to have more of a pain kind of where the incisions are that feels like they did a bunch of sit-ups.
Oh.
And it's a lot more tolerable than that deep down visceral discomfort.
You're right. It is one of the most rewarding surgeries, because as soon as surgery's over, they're like, it's out of me. Like, I feel so much better. Because I can't think of another surgery that's really like that. It's probably the best example.
It can be sort of, anxiety provoking, but when you have that kind of expertise and you're able to explain and be predictive, but I think you also hit the nail on the head, it's this person's first appendix. They didn't get their appendix out before or have experience with it. And I think with patients, I love the surgeons that know that this is the 30th one this month, but this is a individual person that you've gotten to know, you've heard their story, you sort of know what to expect, and it's their first time. And I think that's the kind of empathy and compassion that helps a person and the family go through it, because it's like, we're not just assuming this is going to be, you're going to know exactly what happens. So that's the appendix. Any downsides to having your appendix out? To me, it sounds like you're pretty much going to have to get it out when it's misbehaving and angry and inflamed, because the infection risk is so high. Any downside once it's gone?
There, as a I guess, surgical community, it's a question that's been perseverated on for a very, very long time. And it's one of the I guess, most historic procedures that's been done. And it's
Quite a few of them. It's been studied a lot.
Absolutely, and it's been very well tolerated.
Yeah, and at least we know what to
longitudinally.
expect. We know what to expect afterwards. A person may have certain conditions that we know, hey, your appendix has been out, and that's a good question to discuss. Actually, another good question to ask, right around the time of the surgery or right after. Are there non-surgical treatments for appendicitis?
There's growing literature in the last, decade or so, kind of parsing out who needs surgery now
For appendicitis.
Who maybe doesn't need surgery at all, or who needs surgery later. The easy one to kind of hang your hat on is if you've developed an abscess or something related to appendicitis.
Yeah, abscess, pus in the belly, that's got to come out.
If it's, if somebody is really sick, absolutely. But if somebody has a well-contained abscess, we know we can ask our interventional radiology colleagues to drain this abscess out.
So without surgery, but using X-rays, you can place through a numbed area a very small needle and a tube, and you drain the fluid out.
And we drain the fluid out, treat the patient with antibiotics, and plan to come back down the line to take the appendix out. Because we know when it's gotten so bad that there's an abscess, the safety of doing just the minimally invasive surgery goes way down, and we've learned that these patients end up with much bigger surgeries than they maybe would need to have if we just give it a little bit of time.
Yeah, and you want the patient to be ready, the family to be ready, and as we discussed before, what matters most to the patient is that they feel comfortable with this. It's a shared decision. I mean, you're providing the facts, the expertise, you have then the patient take all that in, and when there's time, unless it's an emergency, I really appreciate that you give them all the time to be able to come to that best decision that's good for them and their family.
Yeah, and we get a lot of seasonal visitors in this area of Florida, and so one of the scenarios where treating appendicitis with antibiotics makes sense is if the appendicitis isn't that bad, there's no warning signs on CT, like the stool ball is still actively blocking your appendix up. Yeah. Antibiotics probably will work in the short term there, right? And get them bridged to go back to, New York and then have your surgery with a surgeon
they're there and they're wanting to come back to Lakeland to get the definitive surgery.
Right. Yeah, and so our evidence says that the rate of having appendicitis come back in the future, if you just got managed with antibiotics, can be as high as like 50%. Okay. So if it were me, I would want my appendix out eventually. But if it was a super bad time for me, then I might say no at the time and do it again later.
Or if the person has all those other medical conditions like rheumatoid arthritis and diabetes, and it's just a surgery is, can we avoid it? And then you think, can I be on the other side of that 50% where the antibiotics keeps it? And I know what to look out for.
Yeah, and sometimes we look at it is we know we have a safe window to start treatment with antibiotics, knowing that gives us a little bit of time to better optimize the global picture. If we're concerned about somebody's heart maybe not being as strong as it is, that gives us time to tease out how can we optimize their cardiac function, how can we optimize their lungs, how can we optimize their diabetes, knowing that we do have empirical support that antibiotics in select patients are appropriate.
Sort of cool it off for a bit.
While we kind of get them ready for a more definitive treatment.
Okay. And Dr. Taylor and Dr. Boucher, I'm curious, just going through your careers, what really got you sort of engaged in surgery, engaged in medicine? Was there something that really got you, had that light, the fire to say, this is a special field. This is such a wonderful career. What sort of led you in that direction?
So I was not one of those people who always knew that they wanted to do surgery going through medical school.
And that's a key point, for say that again. It was you just didn't.
Right. Some people start and they know I'm going to be a dermatologist, and it doesn't change from day one in medical school. And now they're a very happy dermatologist. I didn't know. I thought ER for a little bit, orthopedics for a little bit, and I actually fell in love with surgery from my trauma rotation. And the way you get into trauma surgery is you do 5 5 years general surgery plus 1 to 2 years of trauma. And so that was my plan. And so I was doing general surgery residency with the goal of doing trauma. And I applied to fellowship, got my letters of recommendation, did the rank list, the whole thing. And then the last minute decided that general surgery was right for me. And I haven't looked back, but I still look at our trauma surgeons with a lot of admiration for what they do.
I think that's important for some of our viewers that are younger and they're thinking about their careers. And Dr. Taylor, how did you sort of put things together to go into this field?
Yeah, so similar to Dr. Boucher, I didn't know that I wanted to do surgery in and of itself. As I went through my 4 years of medical school training, it was something that kept nagging on me, like, hey, a little bit of it is the kind of selfish nature of a lot of times we can do something and somebody immediately feels better.
Yeah, I do think it's a personality call. Instant
gratification. That instant gratification. And then from the trauma side, I am a little bit of an adrenaline junkie.
Yeah, you got to act now. You got to act quickly, and it is. I think it's amazing just how you are able to talk with your patients and walk the patients and their families through this wasn't planned, or I wasn't planning on my gallbladder to cause a problem or having a trauma. And I think just being able to really take that in, that's been great. My start was in Iceland. I had relatives who were family doctors and going out on family trips, coming to a house, having a little coffee, and then seeing the patient, then having a little more coffee. But just being able to sit down with the patient and the family and do this kind of family country medicine, and just sort of thought, well, this is just the kinds of neat things you get to sit and talk all day. And I guess that's what the Inside Scope is all about. We want to find out what's really going on, and I appreciate all that. That's some pretty good inspirational stories.
Awesome. And I think that's something that's kind of unique to what we have with our surgery services here. We have 17 general surgeons.
That sounds right.
Between the trauma folks and the general
covering all folks, times of day everything. And holidays and
the old-fashioned stereotype of the grumpy cold surgeon that just wants to be in the OR doesn't really fit the mold of what we have here at Lakeland. I think our group of colleagues has really bridged that bedside manner that you see in the old community family practice doctor with a procedural based specialty that's pretty unique to here. And I think that comes from the community feel of the hospital. This has been an institution here, a stalwart of the community forever.
And the new academics, too, because we're teaching young doctors who want to be surgeons. They want to be involved, and they see that kind of teamwork, and they see that this is the care that's being provided right here in Lakeland. And folks, when they're learning and it's academic, they're on the cutting edge, from robotics to all the skills you're providing, and just sitting down and talking to people. That's great.
Yeah, and I do think that's a stereotype that's still being broken of when we get medical students who rotate with us and they come in kind of scared, right? The surgery rotation is supposed to be a pretty scary one historically, and then they do their rotation the 4 weeks. They're like, hey, that was awesome. We had a great time. Everyone was so nice. And so it's not how it used to be. And I think part of what Dr. Taylor says, because we're a very cohesive group and we all get along, it really has a lot to do with it.
It is cool. And when I get the chance to go in the operating room and just to watch, I see things I've never seen before, and I always learn something. Yeah, that's neat.